is one side of the picture. I'm going to show you one other side of the picture, and also a complex patient. This was a 30 preterm weaker patient, 1.3 kilos, Down syndrome, with complete AVSD, who progressed on the ward on heart failure with diuretics on high flow nasal cannula. He essentially ended up requiring preoperative intubation at around 3 months, and then he went straight for a PA band. After that, he had a very bad post-op period, and with multiple readmission, hypoxic crisis, long-term ventilation, many episodes of reintubation. They thought those episodes were due to pulmonary hypertension. There was a query Malaysia, but again, this patient was not initially a scope. Progressively, because of these reintubation episodes, he developed subglottic stenosis. So the tracheostomy was performed because obviously it was a very complex patient. He had full repair finally at 7 months of age, and he had again a complex post-op period with multiple death spells, with several episodes of cardiac arrest, multiple infections. And at around 1 to 2 months post-op, he was still requiring deep sedation, rocuronium, high FiO2, and sildenafil as well, because of these profound death spells and profound and increased respiratory settings. So we decided to scope this patient to essentially grade and identify the problem. This is a bronchoscopy with a patient moderately sedated, but listen, see what happens when the patient just coughs and he is a little bit more awake. So we have the same proximal malacia that we saw on the other patient, right? Here is the distal malacia. And again, no need to say this is a very distal malacia. So what happens this time in the right main bronch? So essentially you point the carena, you turn the right on 90 degrees. This is the right upper, who is essentially, we would say, moderately malasic as well, closing up. This is with the patient coughing. And see what happened with the bronchus intermedius. When the patient coughs, the airway close completely. So this is, again, a severe malacia. And that explains the malasic episodes as well. What happens with the left? Well, you continue seeing the right. Well, the same or even worse. So you could actually not really go through the left main bronchus. So what happened with this patient? I went back to the patient and spoke to them and told them, listen, there is a very poor prognosis on this patient due to the multipathology situation, and we need to sit down and discuss parallel planning. However, in this patient introduced a longer tracheostomy, well, we could postulate that this led to a moderate improvement, but essentially the patient was still doing bad. And I think the main thing in this case with the excellent multidisciplinary management, we have we used to, when I was working there, we had a good chronic and palliative team who essentially managed to discharge the patient on astral high pressures to the ward. And essentially 5 months later, the patient progressed well. And this is a control bronchoscopy. This is very, very interesting. And it's probably one of the very good optimal surprises I have in my career, to see just such a developed trachea on a patient who had long-term ventilation. In the past, I used to believe that the patient with that severe malacia on the chronic ventilator, with multiple infection, would not progress that well. And the image is quite surprising. This is the right main bronch, and see how it is in comparison with the previous one. That's quite amazing. This is the left main bronch. Essentially, it's wider. It is much more open than it used to be before. So, that raises really the question of how do we really essentially can predict what's going to happen when one of those patients. We could say, and according to some of the publications, that patients with failed extubations, ALT episodes with multi-level and severe malacia are going to be at risk of tracheostomy, long-term ventilation, and surgical intervention. We could potentially hypothesize or assume that if in this cohort of patients, if there is no intervention, no surgical intervention, no stents, provided because they maybe are not indicated, or maybe in your center or in the reference centers, there is not technically feasible. This patient is at high risk, especially if he has superimposed congenital or acquired pathology of dying or have a, dying on the ventilator. And this is essentially one of the main things to discuss. Now we're going just to jump into, I'm going to give you a few examples of treatment. I think some of you guys wanted to talk about this. Hemoptysis and clot removal and biological foreign body extraction. This case is quite interesting. 11-year-old boy with gastric perforation, massive bleeding, severe bronchial aspiration. He's intubated and ventilated. He goes into the major hemorrhage protocol, got a lot of blood. He has his abdomen repaired, and after the abdominal closure, obviously he fails winning because he's got a surprise, a left lung white out. And if you see here again, you cannot see a bronchogram. If there is no bronchogram and a full lung collapse, you can be almost certain that there's going to be a bronchial obstruction. Obviously, very interesting there, just to put your POCUS ultrasound there, just to know. And yes, no surprise, this is what it was found on the bronchoscopy, a formed clot on the left main bronch, beautiful here, just coming out. And this was how we choose to do a combined extraction between all the teams, ENT, respiratory, and us as well. And it took some time just to extract it by the rigid scope. This is part of it, and essentially this is the progression of the child. He initially progressed a little bit, not that quickly as the other one. It required daily physiotherapy and progressively improve. In these patients, physiotherapy is just magic, and it must be the first attempt, the first treatment, even before bronchoscopy, I believe. So the patient was extubated 1 week later and did well. This other patient, very interesting as well, he's 8 years old, has granulomatous disease. He went for a lung biopsy by IR. He suffered of profuse bleeding after the lung biopsy and came to us intubated and ventilated. She was already intubated, and the bleeding improved. However, she came with this collapse of the left lung, and we discussed the bronchoscopy. It was disestimated initially by our respiratory team colleagues. The patient was sedated and paralyzed. Obviously, she wouldn't be able to cough, but she was bleeding. Obviously, the risk had to be balanced. And she was initially on moderate settings, but what happened overnight? She required a progressive increase in the respiratory, ventilatory settings, increased the CO2 and 5O2 requirements, had to go the high frequency ventilation on moderate settings. And essentially, when I came back in the morning, again, no bronchogram with the complete lung collapse in a child who had an hemoptysis. It was clear for me that we're going to have, surprise, again, another bronchial clot as well. So yes, that case, it was in the right main bronch. There was a trial of physiotherapy. And in this case, what we did was just giving through a flexible bronchoscopy, some hypertonic but more than that, DNAs, diluted DNAs. And essentially, the child did actually well. We afterwards went with our forceps and fractured the clot, the cast, and we in this case were able to extract this cast as well. So essentially, this patient progressed really well. This is the X-ray just straight after the bronchoscopy. The patient went back straight into conventional ventilation, moderate settings, FiO2 30%, and he was extubated the following day. So this is something you can only do if you really identify this pathology very quickly and treat it very quickly. And this is something that you can do. Some of you have asked me about bronchoscopy in preterms. Let me show you this case. This is a case of a preterm 27 plus 6 weeks, 930 grams, with partial lung maturation, who essentially was born on on acceptable conditions, into CPAP, FiO2 of 30%, went on the BiPAP, had to have some Curosur,